My name is Heun, I'm a consultant psychiatrist, and this is a disease which you rarely see in psychiatry. I'm talking about Huntington's disease, and you might see it as a liaison psychiatrist to give some advice about the mental health problems related to this disease. The Huntington disease is characterized by a combination of dementia and chorea. Chorea are jerky movements, tics, gross involuntary movements, so people swinging their arms or legs around. They have grimacing in their faces or some dysarthria. Dysarthria meaning that people speak with a unusual voice. There might be an increased muscle tone, rigidity, stiffness, and positive primitive reflexes such as a positive Babinski. And Babinski means that the toes go up when you touch under the sole of the foot. However, this is a very special issue and most people won't bother about that. Some patients also have abnormal eye movement. So the disease is autosomal dominant with 100% penetrance, which means that of a patient with Huntington's disease, the child will have a 50% chance of getting the disease. This might be assessed even before the starting of the disease, which then causes ethical questions of someone knowing that they have a very difficult disease or being very happy not to have them. And if it's positive, then also the patient's children or the grandchildren of the person who have not been tested will know about their increased risk if their father or mother has the disease. Right, the faulty gene is on the chromosome 4. It's called the Huntington gene, and the function is not totally clear. However, the Huntington protein is found in many parts of the body, including the guts, but most of this on the brain. And what happens if there is a abnormality? This means that there are increased repetitions of the CAG coding nucleotide, which codes for glutamine, the amino acid glutamine, and instead of up to 37 repeats, patients with Huntington disease will have 120 repeats of this amino acids in their protein. This then leads to the decay of especially GABA neurons, which are neurons which produce GABA, which is gamma amino butyric acid, gamma amino butyric acid. And these neurons then are more likely to die in the basal ganglia, and this leads to an increased stimulation of the thalamus and the cortex, and it increases dopamine transmission. Right, so in this case of the disease or having this faulty Huntington gene, patients might be developing dementia. They also develop psychiatric symptoms, and this happens in 2/3 to 3/4 of the disease of patients having the disease. Usually the disease starts in their 30s or 40s, so usually juvenile or early onset cases are more rare. The psychiatric symptoms psychiatrist has to deal with is very often anxiety and depression. Psychotic symptoms are very common. Then there is executive dysfunction with a disturbance in frontal lobe, which may lead to impulsivity and aggression. and there might be some subcortical dementia with slowing of the mental processes, apathia, and amnesia. So what are the investigations? First, the blood and the genes. Then in the EEG, electroencephalogram, there will be slowing. The MRI or CT will show atrophy of the basal ganglia and dilatation of the ventricles. And PET, positron emission tomography, might show reduction of the metabolism in the basal ganglia. So there's not good causal treatments of that. The treatment that might stop the disease doesn't exist. Antipsychotic medication might be used for dealing with paranoia, sometimes to deal with aggression, and sometimes also for abnormal movements. So antipsychotic and antidepressant medication are more or less used for symptomatic relief of depression or psychosis. Tetrabenazine, antipsychotics, and benzos are used to help with the abnormal movements. So in general, it's a rare disease which has some quite unusual features, chorea and dementia, and sadly, there's only symptomatic treatment for psychotic, depressive symptoms and movement problems. Thanks for your interest. Bye-bye.